My name is Cassie Trewick. I'm one of the admission counselors here at Tulane University School of Public Health and Tropical Medicine. And today I have the honor to introduce Dr. John Lefante, who will be presenting his Public Health Discovery Seminar Series. And so, Dr. Lefante, take it away.
Thank you, Cassie. So I am, as she said, I'm the chair of the Department of Biostatistics and Data Science here at Tulane School of Public Health. And I'm going to talk today about, the title is kind of a little misleading, but I'm pulling on 35 years of experience analyzing health-related data. And it's not even talking about 35 years, but the whole idea is that trying to give you an idea of the kind of problems maybe you would be able to work on if you were interested in a career in biostatistics or a public health career in biostatistics. So I'm gonna show 2 or 3 studies that I've worked on over the years, a little bit of research study, a little bit of public health practice in terms of program evaluation, and then a study toward the end that kind of does both in terms of looking at clinical and translational research. To start with, my early career at Tulane, I worked with a research group in pulmonary research. We looked at occupational lung studies, quite a few studies. I was in part of a biostat group that analyzed data on a specialized center of research grant, a SCORE grant. This grant was funded by the National Heart, Lung, and Blood Institute. And the type of studies that we looked at were, like I said, longitudinal in nature, and they were looking at changes in lung function for individuals in the workplace who were exposed to different potential hazards. We had some studies on cotton processing. We did studies on chemical exposure. We had a very large study on wood dust exposure, people who worked in the wood industry, all aspects of wood. And then the last project we actually worked on was a Katrina cleanup exposure study. In terms of lung function, the most analyzed measure of lung function is this one called forced expiratory volume in 1 second. It's the one that's the most stable and one we look at mostly. We looked at a lot of different measures of lung function, but I'm going to talk a little bit about this one called FEV1. It measures the amount of air you can blow out of your lungs in a forced expiration in 1 second into a spirometer. And this measure tends to be reduced for people who have COPD or other forms of obstructive diseases that include chronic bronchitis, emphysema, and asthma. And a lot of the reasons why people have these kinds of obstructions is because they're exposed to cigarette smoke and/or outdoor pollutants. So in occupational studies, we were looking at how these different pollutants they could be exposed to can affect their loss in lung function. One thing that we looked at, and everybody looks at predicted equations. We spent some time in one particular study of just coming up with predictive equations for lung function. And so if you've had any experience, you might recognize this, any statistical experience, you might recognize this as a linear regression equation, in case of multiple linear regression equation. And so in this type of equation, we're predicting FEV1. So predicted FEV1 is a function of age and height. In this case, age is a quadratic function, or height can also be quadratic. And what we would do is we have a process in multiple regression where we can estimate these beta coefficients. These betas are actually weights. Okay, so these weights tell us how FEV1 changes as age changes or as height changes. So this would represent, like, for example, the average change in FEV1. Beta 3 would be the average change in FEV1 per unit change in height if you control for age. And then once we come up with these estimates of beta, we can come up with predicted values. We can plug individual ages in, and we can come up with the predicted, and then an individual compared to what they should be predicted would be their percent predicted. As an example, we looked at, in one particular study, we had 5,042 Caucasian and Afro-American men and women, ages 18 to 65. They all worked in paper plants, but they were never smokers, and they had no symptoms of respiratory illness or diagnosis and no history of occupation exposure. So these were folks who were not working in the exposed areas. And based on these 5,042, this is a little descriptive about how they look. Most of them were white men. We had 591 black men and 383 black women. And we had an age distribution that ranged from 18 to 65. All of us, our lung function tends to grow until we get to around 18, 19 years old. And then after that, we find that lung function tends to decline normally over age. And so we were only looking at adults, no children, and only those that had already peaked their FEV and then decreased. And these were the equations we came up with. We actually modeled this, and we came up with predicted equations, and we did separately for these race gender breakdowns. Okay, so that the idea is just, each of these, for example, if we were trying to predict FEV1 for a healthy, non-exposed, non-smoking male Caucasian, we'd plug their age into this equation, age times 0.089 minus this coefficient times the squared age plus this coefficient by their height. And that's what we predict they should be as a healthy person compared to the healthy population. Likewise for the rest of these groups. And so as an example, let's say we had a white male who was 45 years old and whose height was 177.8, and their FEV1 was 3.288. Well, this equation says that they should have this predicted equation to be compared to the general healthy population at their age and height. So we plug their age into this equation and plug their height into this equation, and we get what we predict their lung function to be. And since this individual, we assume, had a liters of 3.288 compared to what we think they should have at 4, the ratio, 3.28 to 4, says that they would be about 81.96 or a little under 82% of predicted. If we use the same age and height and lung function for an African American male, according to our predicted equations, then we'd find their predicted should be 4.28, and which means that same 3.2 liters would be 77% predicted. So each individual can be compared to what we think healthy population should be. Now, those predicted equations are used in most of these studies, and so just to demonstrate one particular, I'm going to look at the wood processing study we looked at, and we published this article 2008. These were my colleagues in the pulmonary group. In this particular study, we had a 5-year longitudinal study, means we followed these individuals for 5 years. We basically had 4 lung function measures over time, annual measures, and we looked to see how their decline happened over those 5 years. And keeping in mind that everybody, if you measured your lung function over 5 years, they're all going to be declining at a healthy decline rate. So the question is there excess rate in this group, and is it based on different exposures? We had 10 different study plants, and some of these people worked in processing plywood, some made cabinets, some made furniture, some were in sawmilling. So different levels of dust exposure, wood dust exposure. And so some of our colleagues, like Dr. Rando and Brizolara, they're industrial hygienists, and they came up with these exposure measures, okay? And so we had different types of exposure to the wood solids and particulate matter, and they come up with what's called a time-weighted average of exposure. And so statistically, if you were the statistician working on the study, what you want to know is what is that measure, of exposure. Now, this looks a little technical. We're not going to get into too much detail, but the idea is this gets a little more complicated than the multiple regression equation we looked at with predicted equations, but it's basically regression analysis. And if you look at this first equation and kind of ignore the IJs and the OJs and don't get confused by the symbols, all this says is an individual's lung function, FEV, can be related back to time. So remember, each individual was measured 4 times over a 5-year period. So each individual had 4 lung functions across 4 times. And so if I take a linear equation that says in any one person's lung function is related to their 4 times, then this pi 1, is the slope of a line. This is a straight line. These slopes tend to be negative because everybody's decline is going down. And the question is whether this slope for an individual is more steep than a normal decline. And could that steepness be due to their exposure? And so it's a little complicated looking model, but basically we're saying, let's take this slope, which is the average decline in lung function per unit change in time. See this pi? And there it is again, the same pi, the same pi. And I'm saying, let's, as a second level of model, let's model that slope as a function of their exposure. And this is a variable called pack years, which represents how much they smoked. Pack years is the number of packs of cigarettes per day times number of years smoked. So we're looking for this particular coefficient is relating their exposure back to their decline in lung function, adjusting for smoking. And again, if you take these, this pi 0 does the same thing for their baseline lung function. It relates their baseline lung function to exposure and smoking. Plugging these more complex equations back into the first equation, and you end up with a function. Lung function can be related back to exposure and time in this kind of sophisticated approach. We have processes, if you were gonna, get into learning how to build these kind of models, then you would come up with estimates of all these coefficients using stat computer packages in a process called maximum likelihood. And you'd be able to fit models that would, like in this example, for example, we could show that the average decline in lung function was related back to exposure, in that this coefficient means for every 1 unit increase in exposure, the average percent predicted lung function goes down by 1.457. Likewise, there's a slight decline due to number of pack years. And so these coefficients are what we're after in terms of what is the relationship between exposure and slope being their annual decline for individuals. If you've had some statistics experience, you've maybe heard about p-values, and we're not going to get into detail. If you haven't, that's fine too. But this p-value basically says it's a measure of how likely it is you would see, for example, the 0.07. It's a pretty small probability that we would see this much of an effect, a 1.5 decline in slope per unit change in exposure, if in reality there wasn't any effect. So the more rare the effect we're seeing under the assumption there is no effect, the more likely we believe it's a true effect. So we're looking for these p-values that are relatively small to be significant. So that's one type of study that we worked on in our preliminary days. Okay, these are the estimates of variance components, which I don't think we need to get into. It gets a little more complicated. So the second type of study that I want to talk about a little bit was I was involved with was something through what was called the Senior Medication Access Program, or CMAP. This is an example of not so much research as public health practice. Okay, CMAP is a project. It's still ongoing, but back in the early 2000s, it was first established in the central part of Louisiana, in Alexandria, Louisiana. There's a foundation there, the Rapides Foundation, that took their money and started a community program where they would provide prescription medications for people who couldn't afford it, and at very, very, very reduced cost. And it's called CMAP. CMAP stands for Senior Medication, but CENLA stands for Central Louisiana. So it's the Central Louisiana Medication Access Program. We in our department, me and some colleagues and a couple of doctoral students, were given a contract to be the program evaluators for this. So in a lot of ways, as a statistician, if you're interested in becoming a statistician and working even at the master's level as an MPH, you'd probably work on these types of studies quite a bit. and you would be involved with probably the program evaluation part of it. One particular outcome we looked at to see whether or not the program was effective was health-related quality of life. And so we used a survey instrument called the SF8, which was created by a company called Quality Metrics. And the SF8 survey was an 8-item survey, 8 questions that individuals responded to that gave a profile of their personally reported health, quality of health. And those scores were summarized into 2 measures that we could analyze. One was a physical component, our PCS, and the other one was the mental component. And so the higher the mental component, the higher physical component, the more healthy or physically fit individuals saw themselves. Okay. So in the early part of the study, one of the early assessments we looked at was whether or not there was, first of all, how do these measures, these PCS, MCS, physical and mental components compared to the general population? What kind of population are we dealing with here in Central Louisiana? And then what is the program doing, if anything, to help those individuals get better? We looked at many other measures other than these. We did a lot of hospital record extractions. We looked at reductions in hospital visits. We looked at whether or not individuals stayed on their medication. We looked at whether or not they were happy with the program. But this is just demonstration of this particular study points to 2 or 3 different statistical applications that you might be interested in seeing. The kind of things you would be doing if you were going to come. If you're interested in quantitative methods and you want to think about a career in biostat, these are the type of analyses you might be doing. Okay, so we looked at race, gender differences in these physical and mental components. Okay, and we looked at the change in the SF8 scores from initial 6-month enrollment in CMAP and reported that for a subset of 342 people. So for 342 of these people, we actually had pre-post measures that we could look to see whether there's significant change. Okay, so first of all, if we were to just plot the initial PCS and MCS for all the individuals in our study and compare it to measures you would see for the general U.S. population, and Quality Metrics actually reported these kind of measures applying their study. They applied their instrument to the general U.S. population, a sample from the U.S. population. And we just plotted our PCS and MCS against those. And you can see that at different age groups, that we got about a 10-unit difference, sometimes a little greater, but a 10-unit drop about, sometimes not quite 10 at different age groups. But our group in Central Louisiana that we're looking at tend to be a little, at least self-reported, less healthy and less mentally happy. Okay. And then if you take that same breakdown by males and females, you see pretty much the same result. You get a little bit of a glitch here and there. This could be due to how many actually in that group. Sometimes the less you have, the less accurate these are. These are means across these scores. So basically we got, somewhere about a 10, 15 unit difference. This is for the males and again for the females. Okay. And then if you actually try to model that, again, these are again multiple regression equations. Okay. So what we do is we take PCS8 as an outcome variable, and we relate it back in a regression equation, but comparing it to age. And this is a variable called a dummy variable, which compares the 2 groups, CMAP to the U.S. population. So basically, we're trying to do this same comparison as in these plots, but we're adjusting for age. Okay, so here we've got, one more time, here we've got a plot that shows age differences in PCS between the U.S. population and our CMAP population, but we do it within age groups. But overall, I want to see whether or not we can come up with an overall difference adjusted for age. And so you can see all these are highly significant if you remember about the p-value having to be small, and they're highly significant. And just to pick on one of these, for example, if you look at the females only, here's that 10-unit difference on the average. That's a difference. That means that the CMAP individuals scored their physical score 10 units lower on the average than the general US population, even after adjusting for possible age differences. Likewise, in the male population, you get a little greater difference, 12.56 after you adjust for age. MCS, you get a drop of about 8.8 and 9.06. So we see that difference that's in those plots, but these are actually adjusted for age. Okay, and then just some summary scores. If you look within, not compared to the US population, but if we look within our groups only, and we compare, say, PCS-8 scores between males and females, we get very little difference, see, between males and females. It looks like African Americans have a little higher physical score on the average than Caucasians. The MCS scores, we see very little difference. We see slight differences, hardly any here. There seems to be a difference between African Americans have higher self-reported MCS scores than Caucasians. And we see a little bit of difference due to age. And also we added to this table on the end the number of diagnoses that they have. So some of these individuals have more diagnosis of problems than others in terms of health issues. You have people with hypertension, some people with diabetes, some people with heart conditions. And so we also have a measure of how many diagnoses they have. If I put all that into a regression equation, I can come up with, within the distribution, within the population, I mean, we can look at the differences, how age, race, and gender affect PCS and MCS if you adjust for number of diagnoses. And again, what are we seeing here? We're seeing that at PCS, we're seeing a slight age effect. As people age, their physical measures go down, which you would expect, but the mental measures actually slightly going up, which could be no effect at all. We see no difference in race for the PCS score, physical score, but we see a slight increase in mental health, self-reported. African Americans slightly higher than Caucasians, and that's significant. And we see some gender differences. And of course, you would expect that the more diagnoses a person has, the less physically fit they would feel. And likewise, their mental scores down a little bit. Finally, we looked at whether or not there was a change in these scores across time. And that's important because we want to know whether or not maybe their physical and mental self-reported scores were going up after they were in the program for a while. And so if you look here, we've got the initial enrollment mean scores for PCS and the 6-month follow-up for PCS. So for example, females in the first row, they initially had a physical score of 37.09. After 6 months on the program, they were up to 40.51, which was an increase to 3.42. Okay, and that was a significant increase. Males went from 38.17 to 39.9, which was also an increase, albeit not significant, but there was a trend increase. African Americans went up by 3.09 and Caucasians by almost 3. For mental scores, they were also going up. Every one of them increased over the 6-month period, which was very encouraging. So the CMAP participants have PCS and MCS scores that are significantly somewhere between 10 and 12 points lower than the US population, which we would expect because they're the individuals in the beginning of the study who needed the medications and probably couldn't afford them. And so, you would expect that they would have less physical and mental self-reported health. Some females have significantly higher PCS and simply lower MCS than males. African Americans had significantly higher mental scores than Caucasians, and we had significant increases in both measures observed after 6 months of the intervention. And so this kind of report was done over time, and as long as we were in the study. We no longer do once I think we did this for 5 or 6 years, and then the foundation felt they were on the roll and they felt comfortable with their process, and we no longer involved with the evaluation. And so the last study I want to talk a little bit about is back to research, but it's research that is translational in by definition. So in some sense, it's not only it's health related research, but it's also public health, because translational research and clinical translational research is designed to take whatever research is being done in the clinical setting and to make sure it gets incorporated into the community. Okay, and so this group I've been involved with since early 2000s, for many years now. It's still ongoing. The LCATS program. LCAT stands for Louisiana Clinical and Translational Science Center, and it's made up of many institutions around the state. Okay, so Tulane is one of the members, LSU Health Science Center, Pennington Research Center, and many others around the state. And the idea is to combine clinical and translational research efforts across the regions and different organizations in the state so that we can improve overall health of the population of Louisiana. It's funded by the National Institute of General Medical Sciences, which is a branch of the National Institute of Health. And you can see it addresses all these areas, and each of these areas tend to be different cores in the program. I was for years involved with the study design analytics group, which was made up of biostatisticians here in LSU and Pennington. Okay, so I worked a lot with investigators here at Tulane, mostly clinicians here, where we do a lot of designing studies and a lot of helping sample size determinations and determining, power of the study before we start. And then in many cases, once data is collected, we help in analyzing the data, which leads to publications. And so one particular one that came out we did a couple of years ago, right after the COVID epidemic, was this particular study that I'm involved with. I'm going to help do the analysis on. And again, to give you an idea of another kind of analysis you might be interested in if you're working on, if you were in biostatistics in these settings. This was a retrospective cross-sectional analysis of 158 African-American patients who were treated between March 12th and April 9th and in the clinic. And the primary outcome in this particular study was whether or not an individual was admitted to the ICU. Because obviously those who went to the ICU had more severe disease. So ICU admission was surrogate for whether or not they had severe disease. And this particular study was actually funded by the LCATS Translational Science Center grant through the NIH. So in this study, we looked at ICU admission, yes or no, as the outcome variable. Were they admitted, yes or no? And some of the potential predictors of whether they were their age, the sex, the BMI, and whether they had the following comorbidities. Did the individual have diabetes? Did they have hypertension? Did they have kidney disease, congestive heart failure, or any of these obstructive lung diseases they could have had? So since this outcome is yes, no, all right, it's an ICU admission, yes, no, it's a little bit different than the first two studies we talked about, because in the first study, if you remember, the outcome was that lung function, FEV1, which is a continuous measure. In the second, the outcome was either PCS or MCS, physical score or mental score, which is a score that they could have, and that would be also considered a continuous measure. The outcome here is yes-no measure. And so the type of regression, if you're going to do a regression analysis, the type of model you want to build cannot have on the left side of the equation just a continuous measure like FEV1. So what we do is we build what's called a logistic regression model. So in a logistic regression model, the outcome is yes, no. So if we look down here at the bottom, where it says y equals 1 if a person was admitted to the ICU, and y equals 0 if they're not. So y is my outcome random variable, but I code it as 1 if you're in the ICU and 0 if you're not. And then I'm going to say let p, little p, be the probability that any individual has been admitted. Mathematically, that means what's the probability y equals 1? If y equals 1 for any person, then that means they were in the ICU. And then this p, which is the probability of being in the ICU, can be related to 1 minus that, which 1 minus p is the probability a person is not admitted to the ICU. So p is the probability they are. Let's say p is 0.3, 1 minus p is 0.7. 0.3 related to 0.7 is the odds that they are versus they're not. And so the odds is P01 minus P is the odds of being admitted to not admitted. And the log of that is called the logit, which is what I take. The log of that is what I said is equal to, on the right side of the equation, something that looks like a regular linear model. So on the right side of the equation, I have potential predictors of odds of being in the ICU. And that's age, sex, diabetes, hypertension, heart failure, lung disease, kidney disease, and the BMI. And the BMI is the one we're interested in. We want to know, see this beta 8? This beta 8 is an effect. You can estimate a number there, which will tell you how BMI is related back to log odds. And the inverse of a log is an exponential function. If you take the exponential of both sides, what you end up with is the exponential of each of these betas is the odds ratio of BMI related back to probability of being in ICU. So if we have, again, you would use a stat package, statistical computer package, to help you find these estimates of beta. We'd use a process called maximum likelihood estimation, more than likely, and you would come up with estimates of these betas, which will be able to be related back to the odds ratio. And then the odds ratio, the beta 8 is going to give me the odds ratio for BMI, adjusting for the rest of these. So going through that process, we came up with these results, okay? Well, not yet. This is summary stats. This is the actual summary we're looking at. Let's see. This is without looking at these are just the number of cases, just some summary statistics. So for example, how many do we have going to ICU? There's 46 in the ICU and there 112 that were not. Okay, and so that's 14.6%. No, I'm sorry, this age, 62, the average age was 62 in those that were admitted and 55 to those that were not. So means that those who were admitted in the ICU were slightly older than those that were not, and that was significant, and that makes sense. Okay, the older people in the ICU. How about male-female differences? Okay, male-female differences, there were no real difference. 39% were male in the non-ICU and 37% in the ICU, and that slight difference was just not significant. That's just probably random variability. There was different in BMI, though. Look, 36.5 was the average BMI, so these people tend to be a bit heavier than those who were not admitted, and that was significant. And there was also different in the BMI distribution. There tend to be more cases of diabetes than is admitted, and that was significant. This is 22 cases versus 47, and that's percentage is 63% versus 42%. There was no difference in hypertension, about 69.6 versus 67, equal hypertension, which is probably not so odd because a lot of folks have hypertension at different levels of hypertension. But 24% of those admitted had kidney disease versus 9%. 22% had congestive heart failure compared to 10%. 26% had obstructive lung disease versus not. So you'd expect that these comorbidities being higher could be one indicator of individuals being put in ICU. And also, you had 37% mortality versus none in this group. Okay, so that's individual one at a time comparisons. Each of these different p-values are based probably on what we call univariate analysis, just one variable at a time. It was either a t-test for means or some kind of a chi-square test for these categorical variables. But if you do that, a logistic regression, and especially on these last four columns to the right, under the adjusted analysis, we can look, last three columns, I'm sorry, adjusted analysis, we get the odds ratios of each of these variables adjusted for all the others. So if you look at this last column, this BMI says that this is an odds ratio, 1.115 is the odds ratio for BMI. That says that the higher the BMI, every 1 unit increase in your BMI, you expect the odds ratio to go up by 1.115, which is an increased risk. And a confidence interval says that risk can be anywhere between 1.05 to 1.182. You also get increases two times as likely to be admitted to the ICU if you have congestive kidney disease. You're 3 times as likely if you have lung disease. You're 2.4 times as likely to be admitted if you have heart failure. You're 1.7 times as likely if you have diabetes. So all of these increase your risk of ICU. And these are all adjusted for the others. On the left side, we have odds ratios that are not adjusted. It's just comparison, one variable at a time. It just shows the risk. But in order to look at whether the risk is adjusted, you need to put into some kind of model. And that logistic regression model allows us to get each of these odds ratio coefficients. Now, this last one says, it looks like, well, a 1.1 or 1.12 risk of based on BMI doesn't sound like a big risk, but this is for 1 unit change in BMI. If you look at a, say, 5 unit increase in BMI, that risk goes up by 1.72. And if a 10 unit increase in BMI, 2.97. So these can be serious increases in risk of ICU based on somebody's being overweight. So finally, the bottom line, with the major health disparities were identified in the COVID-19 epidemic within the United States. And this is one of the first studies actually to focus specifically on the risk factors within the African-American population. In addition to age and obstructive lung disease and hypertension, the study adds further evidence supporting the association between BMI and disease severity. And as a bottom line, the BMI greater than 40 is what as the CDC was saying was people at high risk. This study actually points to perhaps BMI even lower than that could increase your risk. So anyway, that's basically that's the different types of studies that I wanted to talk a little bit about. The first one was basically all research, and the second one was a medication access program, which was a program evaluation. This one is research also, but it has a real implication for public health practice and intervention. And hopefully it gave you a little idea if you're interested in perhaps a career in biostatistics and you want to, you're quantitatively minded and you think you might like to study public health and in particular biostat. And these are the types of analysis you'd be involved with, especially if you're going into the MPH and into public health practice. If you're really interested in the Master of Science program, you'd be involved more with the mathematical and statistical inferential approach to coming up with methods and looking at properties of statistical methods, more into mathematics. But if you feel like you're interested in a very applied approach, that's what these kind of studies are pointing to. And so that's it. So if there's any questions, I'm happy to answer any that I possibly can.
But thank you so much, Dr. Lefante. So I see that we do have a question. Oh, will this recording be sent out afterwards? Yes, it will be. And thank you for joining me. But if anybody else have any questions, feel free to drop it in the chat and Dr. Lefante would be welcome to answer them. So Dr. Lefante, what's the most exciting research you have done?
I think the work we did in pulmonary, some of the pulmonary research we did was fun and actually had some of the implications were important. You know, these lung function measures that we came up with, a lot of the predicted equations that we derived at the time didn't exist. There were a lot of predictive equations, but there weren't any that were derived from workforce individuals, and there were very few predicted equations at the time that weren't just for white men. And so I think that was important. We came up with equations for African American men and women, and I think that was one of the first. At the time, there was a group in Arizona, I believe, was doing a lot of work with Hispanics, and they came up with predicted equations. So that was interesting, and I think the Katrina study was interesting, but except that we came in a little late into the study because at the time, you know, here in New Orleans, we were evacuated and other folks were coming in trying to do research. But that was also important work that we did on Katrina work, cleanup workers. A lot of the work I did in pulmonary, I think, was interesting. Yeah.
So since you talked about Katrina, we have a question for that. Could you describe more any statistical methods you use to assess the impact of Katrina on communities, particularly any related to mycosis and differences in neighborhoods?
Yeah, we didn't do any, we didn't do, so the study I worked on was looking to clean up workers. And so we didn't look at community results, but, you know, early in the game in Katrina, there was a lot of work. The CDC came down and they were interested in determining how many people were back and who was living here and who wasn't. So there were some early studies I was involved a little bit with. Dr. Jeanette Gustad in epidemiology was involved also, probably more than I was. And so, you know, I don't know, I wasn't that involved other than the design, but it was interesting design in what they came up with because it was kind of I'll speak a little bit about the design. I don't know if that's going to help community wise, but if you know anything about what happened during Katrina, well, everybody knows the city almost was completely flooded, right? But there were certain areas of the city that did not flood, in particular, the west bank of the Mississippi River, because the levees didn't break on that side. And then the strip of land right along the Mississippi River, which is the high part of town, French Quarter, and the strip of land right across Lake Pontchartrain, believe it or not, some of that didn't flood because the water ran off. And so the CDC came up with a sampling scheme where they stratified the city into flooded and non-flooded areas. So we had a stratified random sample of flooded and non-flooded. And then within each of the strata, they came up with clusters or neighborhoods where they randomly sampled neighborhoods within those strata. So they had a stratified cluster random sample. And we actually had individuals, students and others who would actually go door to door in community, you know, to try to see whether people were living in certain neighborhoods. And it did this every week to update those, you know, rapid surveys. But as far as long-term, you know, analysis of, you know, community effects and resilience, I wasn't involved with those kind of studies.
Next question is, what advice would you give someone who is starting out in biostatistics, but in a data poor environment?
A data poor environment, does that mean, you know, I'm not sure what that means. Do you mean if you mean you don't feel like you've got enough background in data or quantitative methods, or can you be more specific? What do you mean data? I don't understand what data poor environment means.
We can always go back to that question.
Okay.
The next question is, what unexpected/surprising findings have you seen during your career?
Surprising findings?
Mhm.
Well, we did have some studies in pulmonary where we actually saw some individual plants where um, people who had, I don't know if you can tell this, people who had higher levels of exposure to whatever seemed to be having also better lung function than people who were not working in exposed areas. And again, it was a it wasn't necessarily a real finding because it was when we dig a little deeper, it's all goes back to this adjustment, looking for a lot of ways, when you're doing your work in biostatistics, you're investigating, and a lot of it is being a detective kind of, looking to see for reasons why things are happening. And I think we discovered in that particular study that as we delved deeper into the characteristics of the individuals, we had basically a younger survival effect kind of population, were those who perhaps were not as healthy or were more sensitive to exposure, maybe had more allergic reactions, kind of self self-selected out of the workplace. And so it was probably not so much, obviously wasn't exposure to the agent is going to make you healthier, just that the exposure was for people who already were healthier. But I don't know, that's one particular result that we were all kind of stumped with for a while. I'm surprised.
Next question said,
Mhm.
I missed the beginning, but which part of your research methods are regularly the most difficult to complete?
Anytime you have to collect data, right, and you have to go and do follow-up data collection, it can be very difficult. It it's it's process is time consuming, and then you can, when I talk about these studies we did in pulmonary, just nice, they would design studies where you had every 5 years you go into the workplace and collect data. But if you're in the community trying to do such a thing, like in our CMAP program, well, then you have problems like people who are lost to follow up, right? You want to follow them over 5 years, and maybe some people move or some people, pass away. And so, you always have issues with collecting data. And then the question is, is the data accurate? So in a lot of ways, as a biostatistician, the easiest part is actually doing the analysis. The hardest part is collecting the data and making sure it's clean, getting it into a database that you can talk to you, and have different databases talk to each other. So more and more, the issues is, and especially nowadays, as you probably know, data is becoming bigger and bigger, and more of it's turning into data computer modeling, machine learning, and the whole data science area is how to handle missing data. And so a lot of that is toughest stuff is dealing with the data itself.
So I'm going to go back to that question, that previous question. What advice would you give someone who is starting out in biostatistics, but in a data poor environment? Data poor environment is used to meaning the shortage of data. So I'm going to guess the data poor environment is used for shortage of data.
For paucity of data, I mean, you don't have data to work with? Is that the question?
Yes.
Well, I mean, I think it depends on what you're working in. Like, I mean, in my situation, I'm not generating my own data. I'm working on projects where data is being generated. So if you're interested in analyzing your own data and finding data to analyze, it just depends on what you're doing. I mean, there are national databases out there that you can tap into. If you're trying to collect data, that can be difficult because you have to, have a process for doing it and doing it correctly. So it just depends on what you're trying to do and trying to get into data and just sparsity of data. I don't. But it's not an easy thing to do. I mean, people, generating data and finding in these studies, all of these studies I worked on, every one of these studies, the last one maybe not so much because it was a smaller study, But definitely all of our pulmonary studies, we had a separate group that only worked on data collection and data cleanup and building databases. And then the same thing with CMAP. And we had a small group, and I was head of the group, and I had one person who was only in charge of data management, and 2 or 3 people that were in charge of data collection and data cleanup. So, it's if you don't have the data and you have to go get it, and that's a big part of the process. Yeah.
Anybody else have any more questions for Dr. Lefante? Thank you again, Dr. Lefante, for that presentation. Also, thank you all for attending our Public Health Discovery Seminar Series. You will get a follow-up email with the link to this seminar series as well. Again, thank you all so much for joining, and you all have a wonderful Monday.
Bye-bye.